There are two good points about this session. First of all, we can have dinner after it. And the second point is this is the most engaging session. Rather than us, Tom and myself, standing here and teaching you, we're going to give you the background and then encourage you to participate in our sojourn, in our trip to find out what are the problems that we should face, that we should solve as good leaders in the next couple of years. We'll start with Tom giving you the update on what happened last time we did this summit. We do it every 2 years. We ask you to come in and congregate and set up agenda for what are the issues to be working on, and then we meet 2 years later and see what have we done and what have changed. Tom?
Thanks, Yadin. Of course, we started this process as we started the Congresses 10 years ago, and raise your hand if you were in the room there. Many of you were. And a lot of good things happened. I mean, we were asking Adriana, who's with us now, to, what was the definition of clinical engineering from the WHO point of view. And we did a lot of discussions then. I'm going to shortchange some of the ones Yadin and I talked about this morning. One of the things, though, we said is we needed to get International Labor Organization, ILO, recognition. And what does that mean? That means if biomedical engineering was seen as classified as a health career and health pathway, then the ministers of health of the member states of WHO would have to measure against the biomedical engineers in their health systems and get the ratios right and all that good stuff. We also, 10 years ago, in terms of setting priorities for the profession around the world, 94%, Yadin, after the survey a few months later after the Congress, said we needed a platform. We needed to bring ourselves together and find out our commonalities and our differences and celebrate all that. So let me go on and jump into this program. Yadin, do we want to hear from Adriana now?
Oh, yeah.
Yeah, we do. I mean, you and I are nice, but we want to hear from Adriana.
Yes.
So take it away, Adriana. Oh, before Adriana, though, I'm going to repeat something you told us a while back, and that is you only get to play with ILO every 10 years. And I think that was 10 years ago. And so we've got a new opportunity perhaps in the next 12 months, but over to you. We can't hear her yet.
Just a second, Adriana. It seemed like you're on mute, so let us figure it out. Should we try again?
Yeah, we can't hear you yet, but we're working on it.
Don't worry, Tom, I can work.
Oh,
Yay!
You got it. Yeah?
Yes. Yes. Good. Yes.
Go ahead.
Okay. First of all, I'm immensely happy to be here with you, even online. And I really, really, really regret not being with you physically. But all my heart, my mind, my spirit is with you all this weekend. So blessings to all of you, and many thanks for inviting me to be with you here, even online. Number two is, yes, Tom, actually, Yadin, when we met in 2015, then after that, then we started the famous book on human resources for medical devices, the role of biomedical engineers. And then the ILO definition was 2008. But then with the input that we got that a note that the biomedical engineer also belongs to the health workforce on section 2022. Now, as you all know, I retired from WHO a month and a half ago exactly, but willing to continue working on this so that we can get more recognition for our profession in the healthcare environment. But later on, if you allow me, I can even share that now with the health workforce, when I was working still in WHO, there is like a survey that they're asking countries, and we have an area there and a survey there, and it's been monitored by countries. So it will be really very important to continue this work and to ensure that the biomedical engineers, clinical engineers that are working in hospitals are recognized by health ministries, not just working in hospitals, but also working in the ministries of health. With that, I will stop and I will follow the rest of the event. Thank you immensely.
Thank you.
Thank you, Adriana. You set up perfectly for the session, and we went through the aisle of history. And what I would like to do is to tell you that the process is covering what we have done. Tom will do that. Looking ahead, we will ask you what are the challenges you have today. We will categorize those into single mode operation, and then we'll vote on those challenges to rank them between most important and least important. That's the process. In between, we would like to know who is participating, who is contributing the challenges, and who is going to rank them at the end. And to do that, we have polling questions. And we will put the polling question. We were able to generate a QR code that you will be able to point your phone at. And this is streaming live around the world. So it will be participating with people beyond this room, beyond this hotel, and beyond this country. So here are the polling questions. Let me see if I can do that. So it said here, Global CE Summit 2025, and first of all, we start with demographics. Please enter your email. Question 1, are you practicing in, and there are categories. Need to be able to read it.
Been there.
What are the geographical locations you are in? Asia, including Australia, Europe, Africa, North, South America, or other location? And question 2, your gender. We only have 2 choices. Can we give you 5 more seconds? Make your choice, vote, and we close the voting. Can we show results?
There it is.
Fantastic. So Asia, including Australia, about 1/3, Europe, about 1/5, Africa, 10% about, North and South America, about 33, so 1/3 as well. And in other location, which I wonder if that's the International Space Station, we have 5%.
Space Force.
The gender is still male dominant, and we're trying to change that as much as we can. We are making the effort. Okay. Can we do another poll question. This one will be about profession. What is your background? And we need the QR code. Adriana, are you voting?
Host and panelists cannot vote.
Okay. Global Clinical Engineering Summit 2025. The topic is profession. We have 2 questions. Again, put your email so we know it's the same person. Do you consider yourself practicing in? Multiple choice. We request that you select one. Are you clinical engineer, other engineer, technologist, technician, clinician, administrator, academician, manufacturers, vendor? And the second question is, tell us a little bit about your level of practicing. Are you practicing between 1 and 5 years, 6 or 10, 11 to 20, 21 to 30, over 30?
We need another category. It has to be measured in centuries.
And once you select, please submit, and we'll give you 5 more seconds for those of you with over 30 years experience and a little bit slower.
I resemble that.
And we'll close the voting, and let's see if we can have results. "55%, over half of you are clinical engineer.
Kind of a gray crowd out there.
No technician, that's surprising. We have some clinicians, some administrators, and the next high level is academicians and couple from the industry. Okay, and as far as practicing level, 21 to 30 years is 1/3, 1/4 is over 30 years. Oh my God, I thought I'm gonna meet some teenagers here. No way. Okay, that's good reflection, so you know who is opining and participating. Tom, back to you.
Well, first of all, whatever you see on our faces and body language, this is supposed to be fun. So start having fun. And I'm going to look backwards in time. Callie, so I can just see it there, I guess. So who are we? And everybody knows the answer. We're, well, the GCEA is over 66 countries, and before the end of the week, we think we'll be over 70. We've been talking to some of you folks. And 50,000 members now from 66 countries. And we have, you know, we set up that network in recent years, and Adriana, I did put countries and territories in there. And we're all kinds of people and a growing percentage of women. Next, please. So what did we do 2 years ago in BIZAG? We did the same kind of process, and we came out with the priorities as you see here. CE Impact was 1, capacity building 2, more to say about these, recognition, credentialing, body of knowledge. So, and the other 2 questions were the developing your national society and developing HT policy. And Adriana would tell us, if I would shut up, that WHO has just been working on a updated WHO policy book in 2025. Next. So what am I going to do now? I'm going to look at those top 5 recommendations, and I'm going to say a little bit about what GCA with you. GCA is you. I mean, and you know, even if you're not a member, we've been working with you around the world and developing the answers here. So this isn't just about us, you know, up front. It's about all of you. But how have we increased our impact of our profession? And he doesn't have his hand up. He's just changing. We increase clinical engineering engagement locally, nationally, and globally, and we've done that during the COVID years, certainly working with Adriana as she requested around, and had 160 countries of our colleagues get involved. And you know, another COVID thing, even though that's more than 2 years old, is I want to talk about Dr. Elliott Sloan leading a team that looked at all the information and evidence being published during the COVID years, 20 to 2023 particularly. And 5 days a week, we brought a team that Dr. Sloan led saying what was most relevant to you to know about for 800 straight weekdays. So that's a... But specifically in 2023 till now, we've been working with, GCA's been working with challenged countries. We've got a friend here from Haiti, Pajo here ABE Clin that's recognized here from Brazil is, and don't worry, I'm not gonna go every last detail, but I wanna talk about it a little bit. Our Brazilian friends have been working with Portuguese speaking countries, particularly in Afro, and thank you, Pedro, for particularly leading that. And then Kisa from South Africa and Tim's at the back and Mladen's here have been working across Afro with, in ways you've seen there. And our Italian friends strongly represented here, and other European member societies have been bringing in other member societies and doing a lot of great work. AMTZ that you heard from before with its fellow program, and they've got like 3,000 certified biomedical engineers in 1 of 5 categories, so that's very cool. And a growing presence in the Americas. So we think the impact thing has been pretty good. Next. Capacity building, always a challenge. One thing though we did in recent years that we started to use this tool was the capacity building framework that has the buckets of knowledge. You can see here the subcategories: investment and competencies. Are we preparing people well and training them and developing them? What's the investment from the outside into our profession? How's that going? And what are we increasing our competencies? And you see that we did that across low development, middle development, and high development to give some people to shoot for. And we have done a lot of capacity building and use this tool, as you see in Adriana's led 5th Global Forum in May, in the webinars that we did, GCA facilitated with local partners in 2024, the work in the Americas, in Southeast Asia 2 weeks ago, working with AMTZ and its fellows program. You heard a little bit about that earlier, through China and many European programs. Next. So we think we've worked hard to build on capacity building. Have we done everything we need to? Of course not. Professional recognition. I'm delighted to say that GCA from 2 years ago has grown from a presence in members in 22 countries to 66 countries. And so that's pretty cool, Mr. President. And we've also developed a platform since the 5th, this is the 6th, right? ICT HTMC, to identify, educate, and contribute and share best practices. So through our webinar program and a bunch of those that are not covered up too much, and through our tech snapshots. So we're educating a lot to bring recognition and tools to our constituencies. Next. And to others around the world. We don't limit all these webinars are for everybody. Professional credentialing. In India, in Vizag, that was the city where it was held a couple years ago. And leading up to that, we've talked about credentialing for years. The problem is we haven't made that much progress. But India has. This is where the 3,000 people have, in these categories, have been certified and served during COVID across that country. Does that mean we're not doing anything across the rest of the world? No, but we're not doing it in a way that helps one another yet. So not a good grade on that part of the report card. Next. And this is the last one, and then we're getting to the meat. Do we have a uniform body of knowledge and body of practice for WHO's defined CE practitioners? Adriana, a few moments ago, said they measured how many CE practitioners there were, in this case in 2018, across 130 countries, and came up with a good number, and that helps drive this ILO decision-making and so forth. And that is engineers, technicians, technologists, HTM managers. It's not just 4-year degree and more folk, even though that's cool. But how have we worked on body of knowledge and body of practice? Well, there was supposed to be a workshop right now that we didn't get to it, but I know Mladen and Khalil will get back to it and reschedule it, because they had a lot of cool things to say about that. But the journal, Yadin and Jindong and Caleroy have led the process to get a ton of global best practices contributing to body of knowledge and body of practice. The accreditation process, the workshop that started things in this room right after our earlier program, is a great chance to standardize our practice and to measure departments against it. And then our partnerships, which are very diverse, as you can see here, through the COVID years, particularly Every Breath Counts, but many others presenting at IHF, International Hospital Federation, working with Humatem from France, but across French-speaking Africa. I can mention others. Pull Alliance takes the whole digital health approach and takes successful health delivery programs and makes them better with digital health tools. So I think we're working hard on that. Are we where we need to be yet? Probably not. Next. So here's where the part where we start to have more fun. Yadin, these are the things we polled on 2 years ago. We came up with the 5 that I spoke about. I want to make clear what we're perhaps choosing now. There's some things missing. Maybe something about AI is missing. We could try to type that in, but we won't right now. But so are we making measurable impact through the various stakeholders we work with, like ministries of health, hospitals and health systems? Are we making measurable impact through industry, academia, regulatory, and through our various stakeholders? A year ago, Dr. David came to me and said, in any of GCA's projects, I'd like to embed more compassion, kindness, integrity. That's a pretty cool thing. So we've been thinking about that this year. How can we work on capacity building, particularly adding digital health tools to what we're already doing, because that's where the world is going. That's where healthcare is going. And how can we work on these other, and under body of knowledge and body of practice, I know you want me to particularly say, how are we working on leadership development? How are we working on innovation? Certainly Dr. Sharma and others spoke about that this morning, and Jen Dong did. So Yadin, come on.
Great. So we cover how it was done before, what we find out based on your input, the priority and the categories. I don't know if Adriana can hear us. Is she still on?
Yes, of course. I just put my video off while the slides were being presented, but I'm here.
Great. What I believe is that if you go for a vote, you need to put the foot on the balance, so it will go your way. And I would like to ask you, if we have those 7 classification on the screen, if you can see that. I think they voting against me. They give me microphones with no batteries, Adriana. So maybe you can hear me better now. But,
yes, better.
But
thank you.
The 7 classification of preferences that were voted on last time, what would you say that not the order, but are we missing a topic? Would you add, would you delete for those 7 categories?
Yadin, I think something that is really important is how the clinical engineers can work in a health technology management unit in the Ministry of Health. So that has to be somewhere. It will relate to the policy, but it's really empowering those clinical engineers to be managing the technology in countries. So I don't know if that would be a mixture with number 6 or in a number 8 as what else, but it is like a policy making, like implementation of policies.
So you see it a little bit more than one.
Yeah, because through the Ministry of Health, but it is different if you work in the industry or in a hospital than if you work in the Ministry of Health and develop the policies for the whole country. Okay. So I will just put it somewhere else, or capacity building for health technology management at the ministerial level. I don't know if we should consider it in a different number.
We got your point, And by looking at head nodding in the audience, seem like people suggesting that should be a category on its own. It's a bigger vision than what we have.
Yes.
So
Yes.
what I would like to do at this point is go to a polling question before the vote is the last one. Do we have the professional purpose? Just a second, Michael. We're going to another vote, another polling question. Okay, disappeared. Global CE Summit 2025, professional purpose, email, and 3 questions. Do you feel that your work impact patient care? Do you feel that your work is recognized? And do you feel that participation in the national organization is important for improving patient care? You have multiple choice. We'll call for a vote. We'll give you 5 seconds. Okay, close it. Let's see. And sharing the results. Do you feel that your work impact patient care? One is not sure, but all the rest are saying yes, Adriana. That's great. Do you feel that your work is recognized? That's improvement from 2 years ago. Over half saying yes. 1/3 saying somewhat, and only 10% saying no or don't know yet. And we would like to improve that. Make sure that you do know. And the 3rd question, do you feel that participation in international organization is important for improving patient care? 82% saying yes, very much. Additional 14% say yes, somewhat. The Italian, I guess, said no, sure. Great, that's very good information. Let's go and at this point and start see if we can accept new categories that need to be added to the list, and then we'll go to ranking it. Mike? Can you greet the microphone?
I'm just going to comment while we're waiting for a second on Adriana's comment. 10 years ago, Adriana, remember you left China to go to Johannesburg, helping organize societies, and you were lamenting that you didn't have a lot of help. And I know today there's been improvement. In other words, you have a biomedical engineer in most of the regions, WHO regions of the world, or you did in your just past role, but you don't have enough. WHO doesn't have enough of us. You might want to comment.
Thank you very much, Tom. No, I should say that I'm really sad about the current situation because my post was abolished when I retired because of the restructuring. So the issue of the funding for global health is going, it it really decreased in this last year. And not only in WHO, but also in many of the NGOs that are providing support for aid in health in general in the world. So what I would like to say is only the Eastern Mediterranean Office has a biomedical engineering full-time and the Southeast Asia region. But the rest of the regions have no biomedical engineering full-time assist, and PAHO, the Pan American Health Organization. But the rest of the regions do not have, number one. Number two, there are many biomedical engineers, clinical engineers that are needed in country offices for WHO. There are some in the Atomic Energy Agency, some in UNICEF, some in UNOPS, UNFPA, UNDP. But what is important is not only having them in WHO, but also having them in the governments. So are the clinical engineers reaching a high level in their Ministry of Health? That is a question that maybe we should ask ourselves. Do we want to stay in our hospital doing maintenance, or do we want to go up and do planning, needs assessment, or we want to go even higher to go to the Ministry of Health and work on equipment planning, nomenclature, maintenance policies, or so. That should be, I think, our aim together as a collective group of clinical engineers. We have to aim high. That's my big message. Let's aim high. Let's aim to manage the policies of health technology management at ministerial level. I would like to say that there are WHO World Health Assembly resolutions on regulation. There are health technology assessment on health technology assessment. There are others on oxygen, there are others on the diagnostics, but there is no resolution specific for health technology management, although there are many resolutions that call for it. And as you know, the resolutions that come to the World Health Assembly, they have two components: what WHO has to do and what countries have to do, or at least would be willing to do. So my humble suggestion, Tom, Yadin, and colleagues, is that we have to aim high. We have to encourage our colleagues to go to have an office, even small, start one person, but at the Ministry of Health to do policy for your whole countries. Besides, and having the backup of the international societies like GCA, we can all support each other to reach those goals. Over.
Thank you.
My turn?
Thank you.
Thank you.
Is it my turn to have a question?
Yes, Mike.
Do you hear me?
Yes.
Adriana, it's so good to see you. I'm Michael Chen. I'm here. I'm here with the conference. It's so nice. It's the first time I'm in China's conference. So glad to be here seeing all the old friends. I agree with you entirely that we need to aim high. We need to have the clinical engineer more recognized. The key is that we cannot just speak this clinical engineer's language because they don't understand. We must have some simple way to convey the significance of clinical engineering. And I believe that the chapter 53 is called Medical Device Regulation and Patient Safety. Now, have you read that chapter? Have you read that chapter? Okay, if you don't, let me remind you.
Michael, we're not going to take a lot of time to review your chapter right now.
No, I understand. I'm not asking you to review it. I'm simply asking, just trying to tell you that that's a simple message to get the people high up in the Ministry of Health to understand.
That's one of the voices they should listen to.
Yeah, but
Agree.
it's my turn. You're not questioning me, Tom.
No, but I'm going to ask you to stop in about 1 minute, so please make your point.
Okay, that is a 3-step to patient safety. And that is derived from regulatory principle. That one is really based on safety. And now, a good message to you is that there is the recent European European healthcare policy. It's a top-level policy. It's called Improving Healthcare Quality in Europe. And this is published in 2019, 2020. I was a contributor to that. And in there, that 3-stage level of the framework is recognized as a safety base on top of the EU directive for regulation. Now, the problem with me is that people hardly know my work, and I've been working behind the scene to promote clinical engineering. So there you are. I'm just trying to give you good news. Those are good things to present and promote to get the high level recognition. It has now been highest level of policy document, recognizing that 3-stage clinical engineering work as safety, ensuring safety after regulation. I can detail this, I hope.
Thank you. Thank you.
So thank you, Michael. I think that's important. But getting back to the question that was asked, the polling, could we go back to those 7 questions,
Yes.
please?
Not question, but topics, you're saying.
Topic, sorry.
And I think in the policy
Yeah,
one, we're
that one, yeah.
refining it to Adriana,
Yeah.
aim high. But back to you.
So going back to what Adriana said about clinical engineers in ministries of health, Department of Health having impact. But look at the title of our Congress. It's International Clinical Engineering and Health Technology Management. Now, a lot of colleagues, even societies, recognize those as being synonymous. But in fact, they're not. And I think it's important that we recognize that difference. And I think Adriana's alluding to that. One could argue that all clinical engineering practitioners do some level of health technology management for which they are responsible, and I accept that. But just as an illustration, when I was Director of Health Technology for our public sector health department in the Western Cape, my 3-star deputy directors, one was a nurse, former nurse, one was a radiographer, and one was a clinical technologist. But they were excellent health technology managers. So I'm asking you that we don't paint ourselves into a corner, but we, for each, wherever CE is mentioned on that slide, we should have stroke HTM, because we need to bring into our family, and we need to be part of a greater family of health technology managers and those who do health technology management who are not engineers and engineering practitioners. So that would be my plea.
And I think we tried to start that at the beginning when we said CE practitioners as defined by WHO. So yeah, CE is CE practitioners. Point well made.
Parminder, your hands up.
So I'm new to this, but I don't know if it's going to be appropriate. But looking at it from my perspective, when we look at the capacity building topic and look at digital health skill sets, one of the things that's becoming very prominent now is that this technology is moving out into homes and communities for people to be able to self-manage. And so it would be interesting to think about citizen skills in terms of being able to select these technologies and what the role of the clinical engineer is in providing support and making the right choices and decisions. And then following on from that, I think we also need to think about reuse and sustainability, because once the technology starts to get out there, just like crutches and wheelchairs, it doesn't come back. it gets lost in the system, which is a big waste. So being able to think about how we can use digital tagging, Internet of Things, etc., would be interesting. And then just one point related to that, and I guess it comes back to safety, is once the technology starts to get out there, we have to think about legal aspects and liability as well. With the consumer right to repair initiatives, etc., what does that mean once you break, to try and repair something, you sort of break the validity of that certification, etc. So those are my points. Thank you.
Omar.
Hi, Miranda. I am Omar Hussain from Saudi Arabia, chairman of MIMBA. Actually, we have to think to make up our compass point into a direction and reformulate our way of thinking about clinical engineering. The way we are thinking about is that started from hospital. It's not that I believe the clinical engineering started from manufacturing. Because if you are not manufacturing medical devices, if there is no medical devices manufactured, then there is no clinical engineering, in fact. So how we can be instrumental in this equation, manufacturer and healthcare provider, and there is a clinical engineering in the middle, without being so competent as the manufacturer who is manufacturing this equipment, and not to act only as a patient safety and efficacy, because I don't believe on patient safety if it's not economic wise. We have to believe on consumer rights and how to protect the consumer, and to speak the same language as the manufacturer is speaking, which is regulatory, by the way, and the same language that the clinicians speak, which is clinical. So I believe biomedical engineer is clinical, is a misleading term. It's a clinical engineer is the right term, with the competency of manufacturer.
I hope you guys are taking notes, because we will ask you to start putting classification in addition to what we have. And you heard from Adriana, one is the national level policy structure.
I was just going to say, one thing is quite important to mention is medical technology is about 15% of capital expenditure in health, and also about 12%. Medical technology is about 15% of capital expenditure in healthcare, which is a quite significant amount of money. And also 12%, around 12% of carbon footprint, again, is assigned to medical equipment. So I think from both sides, you can push the health ministry to understand the importance of understanding how you effectively manage both the capital. So whether we as clinical engineers need to upskill ourselves around commercial element of it. So for example, in UK, the Med Technology Directorate for healthcare state is an ex-procurement guy, not a clinical engineer. So, which is quite understandable, because the amount of capital spent in here requires significant amount of commercial understanding. But also from sustainability point of view, we're going to have to upskill ourselves in order to play in that field. And as she mentioned, is just bring it up to the ministry level to make sure we have a voice in there.
So you think it would fit into existing classification, or you're proposing a new one?
I think the sustainability is definitely needs to be a new, because there's digital, which is quite paramount, and then in digital itself, medical device as a software as a medical device, it's separate classification, because digital is usually assumed equipment with digital connectivity as opposed to, and AI. But the software as a medical device doesn't fall either of those two. But also sustainability, I think, is quite important for us to add into this, to make sure that we have a voice.
Okay. And Ricardo is holding the microphone.
Yeah, two categories, and I'm just going to echo and expand on what Praminda and Omar said. So one category that we need to have there is distributed care. Clinical engineers need to go beyond the hospitals. In fact, the big hospitals are dead. The hospital future is hospital at home, where you need to manage 20 million potential hospital beds, and you need to get devices, distribution, supply chain. Those are a whole set of skills in the capacity building that we're not even mentioning there. So we need to build. The distributed care is one category, and the other category would be life cycle management, and there we can include research and development, we can include end of life, reutilization. All of those categories will fit into a life cycle management.
If I would give it to somebody outside the room, I'm not sure that they will understand distributed health. What do you mean? I don't think the title is clear.
Well, let me elaborate. Okay. So, Internet of Medical Things, okay. Wearable devices, hospital at home, telemedicine.
What about it?
All of them fit into that distributed care category, where your medical device is not at the hospital. The medical device is traveling in the wrist of the patient. Who is ensuring that those smartwatches are calibrated, are regulated, are harmonized, are interoperable? Who is gathering the data to validate the data sets to build the AI engines that are dependent on those distributed devices? Excuse me for
interruption, but you are not getting my point. If I put distributed health here, it's like I'm saying the sun is rising. So what? What do you want to do about it? Capacity building is clear to me. You're talking about competencies, right? You're talking about volume of workers, body of knowledge, body of practice. I understand, unified, identified, but I'm not sure that I understand what you mean by distributed.
We're looking for actionable steps. I mean,
understood.
It could be under digital health skill set.
Yeah,
It could be part of capacity building, or
now you're clear. Okay. Yes.
And it should also be part of credentialing.
Okay.
Okay. Yeah. So, Juliana, it's very. It's my pleasure to see you here. I thought you were joining us this time in Shenzhen, but unfortunately, turned out you still couldn't manage to join us. So I just have one comment, because I remember very clearly 10 years ago in Hangzhou, the first ICE HTMC, and regarding the professional recognition, it said currently in the 2008 version of ILO, the professional coding system, the BME do appeared, but in a category named not classified in else, and also in the industry section, and not in the healthcare professional section. And I remember that 10 years ago we talked about it. It said, first goal, we should move, the BME also in the healthcare professional section, also appear the BME name. Second, and we hope we end clinical engineers and needs the BME as a part of healthcare professional section. So my comment is, how about this go? Because the ILO currently only have the 2008 version, and normally 10 years revision, but still no new version released. So my comment actually is, do we still seek these objectives, say, to move BME or CE and appear in the healthcare professional coding system?
Yeah, okay. I know over the years you reminded me of this being under other engineering profession, not in healthcare, not in clinical or biomedical. Adriana will tell us that this is only part of the fight. The biggest issue was when we never got over 1 million count of practitioners. So it doesn't matter what you call it. If the ILO is saying we need to see at least 1 million practitioners and we don't count it, we'll never get there. So we need to be able to convince the world, please, when we ask for a survey, send us the response, show us that you count. Adriana, is that correct?
Yes, thank you very much. May I comment?
Please.
Okay. Shenkun and Mladen, Yadin, etc. I really value your comments and I'm taking note of everything. Okay, number one. As clinical engineers, we are responsible for the last mile of the use of technology. We have people upstream on the regulatory issues. They're doing their work, but they deal with papers on laboratory approved something. But we are the only ones that deal with the last part, with the last mile. And there is nobody else there. And I agree with Mladen that we include radiologists, nurses, everybody else on the management of technology at the end. That's on one side. And I may say, I put it in the chat, the new book on policies for medical devices include all the areas that were commented also before about sustainability. That is totally new. AI, that's totally new. So we didn't consider that in the 2017 publication, but it will be, and today I received it, even though I retired, I left it like 99% done. It is on the publication approval, so hopefully before the end of this year, we will get it, and as soon as we get it, I'll share with you. Number two, Shenkun, on your concerns about ILO, I fought for that when I was in WHO. The human resources director, he fought with me also. So the thing that we achieved to change is what I put in the chat right now. That is, the biomedical engineers are considered to be an integral part of the health workforce along those occupations classified in sub-major group 22 health professionals. And yes, I remember saying, number one, we need to get the biomedical engineers. And once we get them there, then we can see, okay, a sub-specialty or subtopic of the biomedical engineers are the clinical engineers, because in many countries, the certificate or the accreditation or the university title that they get is as biomedical engineers. So we need first to raise the numbers, how many we are, where we are, and then secondly, go back to the ILO as the professional societies. I will not be WHO by then, but we can do it through GCA, through IFMB, HUMATEM. We can get many of the NGOs, organizations together and make a proposal to ILO. That would be my proposal. Over.
Thank you, Adriana. Stefano?
Yes, thank you. Well, I would like to go into a detail of the point that Nata was raising, and now also Adriana mentioned, of medical equipment sustainability, in order to make it a bit more practical. I mean, if we put as a title medical equipment sustainability, it can mean many things, and at the end of the day, you don't know what really talking about. One thing I have seen participating to a couple of projects in this is a lack of some standardized way to assess sustainability of medical technology. If I have to put sustainability as a criteria for a public tender, what do I ask vendors? What do I measure? There is no standard. COCIR in Europe tried to do something about radiology for electrical energy consumption, but then it almost died, the initiative. And in other sectors, I talked with vendors of steam sterilizers. Can you agree on a standard way to measure water consumption so that you can present data that is comparable and there is no industry standard? Or the impact of manufacturing. Any vendor can say something, but then you don't have some standardized way. So I think that having a point on developing methods for the assessment of medical equipment sustainability could be a practical goal that we could play a role with.
Thank you. Khalil?
I think if we pay attention to what Adriana said, mentioned before. Is what she really means, if I understood you right, Adriana, was to, you meant understanding the clinical engineering profession and to know where we want to go. I think that was what you mentioned. And today, GCA has, as you said, 68 members, different countries. So we have a big number of people that can discuss with GCA what they want from clinical engineering and what they want to go with clinical engineering. So my point is just going directly, when you say credentially, is credentially what? If you don't know, if we, GCA, don't guide them to say, look, this is the expectation we have for clinical engineers. And then we could guide them. We could set a set of disciplines or knowledge, whatever, to tell them this is what the core of clinical engineering should know and what you expect from them, what you want to go. Because we have so many different, let's just say, clinical engineers in the States go for the management. Clinical engineers in Brazil go for maintenance. So what are we expecting? What we want to do? That's, I think, what you were asking for, Adriana, if I understood you right.
Looks like Adriana is nodding head yes. Hashem.
I'd like to answer Stefano about the standards for sustainability. The task force has included 8 standards within the GCE accreditations. And we welcome any suggestions or ideas to increase the number of standards. And that's one thing. Another thing about the list that you included, I would suggest to add 3 more items. One of them is HTA for medical devices. This is really lacking in many countries, even in the US. So that's one thing. Some countries, even WHO, they started doing some work in PAHO.
Number 2, what's number 2?
Number 2, I would say clinical engineering accreditation. Yeah, I see that
as individual, not programs.
No, as departments.
As departments. Okay.
Because I look at
as department. Okay.
Yes.
I don't care what you look at. Number 3.
Yeah. I think accreditation. I say my point. Accreditation is like a cherry on the cake for all the work that have been done.
Okay, number 3, what is 3?
Number 3, we have, there is, especially in third world countries, there is a lack of support from third parties or from OEMs. So if we have a category on third parties and OEM support, these are the 3.
So like I tell Ricardo, I need action item. Third party, lack of support. What do you want us to do?
Support of OEM, for example, if your CT or MRI is broke, sometimes it takes you 2 weeks to get the part. So if the manufacturer, I worked with manufacturers, if they know there is guidelines to follow and they are adopted by the FDA of every country before purchasing.
So what are you suggesting? To
have guidelines for the support for OEM and third parties.
Now it's clear. Okay.
Yes.
That's interesting. Yeah. What I would like to do at this point is that I would like to go to the process of creating a new list. And I will start by saying that once we have a new list, we will agree that we will designate region to work on certain part of the list. So it's not everybody work on everything, okay? And I will start by saying is the 7 categories that are here should be eliminated, and if they are needed to be added, this is a separate question. Right now, just tell me if the 7 that you see can stay like this, need to be deleted or modified. Neta.
What's the difference between professional recognition and credential? Because when you're talking about clinical engineering credentialing, do you mean individual or services?
Professional credentialing is the ability to have recognition that we had achieved competency level that is somehow benchmarked according.
So number 3 is a personal one, number 4 is a service one?
The difference is that
because like in China, why I comment that ILO? Because each country will develop its national level professional classification coding. And here, in China, we also this issue, but there's no recognition for the clinical engineer or BME in the healthcare professional section. So during currently situation, I echoed Angeliana's previous comments about the general. I mean, in here, a lot of the hospitals, because the economic situation is not so good, and they either cancel the department of in-house clinical engineering or said from next year, no new person allowed. Because if in the professional coding, there is a clinical engineer or biomedical engineer, then the hospital must support it. Otherwise, who are you guys? So by my understanding, the recognition is by others or even by the government. But the credential, the Society of Clinical Engineer Society, we can develop some of the credential programs. So that's my explanation.
Thank you.
That's why I'm saying it's very important,
clarified.
because also currently in the globally, I mean, the shutdown layoffs phenomenon is very serious. I also heard Tom said the cancer permeating canceled the total HTM team. So you just suppose, I mean, you just think about this time. Okay,
so you're right. One is competency, the other one recognition by others. So going back to my question, do we have an agreement about the 7 topics staying as is? I would like to see hands up. Hands up.
I mean, perfect's the enemy of good. None of those are perfect, but they're close, I think is one thing we're saying.
Okay. Let me ask it a different way. Do we need to delete any of those? Hands up. I like it. I'm holding a gun. Hands up. Okay. Sorry? Modify is the third question. Modify, not delete, keep, now modify. What would modify?
Number 4, credentialing and job security by means that no intruders to the other than clinical engineering doing the job. So
not good.
It's similar to the physicians. Physicians are ophthalmologists cannot do the job of the cardiologist, and if he do, his license will be withdrawn. So
that's a result, but that's not something. That's better. That's better. Like if you're not certified, you should not hold this position. Yeah. But if you're saying job security, I'll always say we're not here to provide you secure job. We are here to provide you professional standing.
As Miranda said, that there's no boundaries defined for biomedical engineers. Her post has been deleted, so nobody is. They believe that the task can be
so
integrated in
I got your point. Okay, so you're saying let's move it to number 4, credentialing and privileges.
Right.
Okay, can we start making a list? Okay. Just because you run the show doesn't mean that. So we prepare a vote on those classes, categories, and in that you will find one free script line that you can enter a new category. Just a moment, we'll be right back after this commercial. Okay. Can you take the list of 7 and modify it?
I can put up the poll of the voting. That's
Yeah.
right.
Okay. Here you go. Yeah. Global Clinical Engineering Summit 2025 voting email, and then you have 5 questions. Please vote for the most important topic we should be working on. You can have single choice. We were trying to get you choice 1 and choice 2, but it seemed like not working well. So we'll go to question 2. Clinical engineering involvement with decision makers. So Adriana point, like Ministry of Health. Number 4, do you have adequate professional development training in your locality? Number 5, have you read any of the manuscript published by the Global Clinical Engineering Journal? This is kind of a commercial.
By the way, the journal came out of an earlier prior study.
Yeah. Okay. Do you need more time? Question 2. You can avoid question 2. What we try to do is give you 2 choices for question 1, and it didn't work. So we were with intention, but bad producers. Okay, we close it in 5 seconds. Tension is up. Okay, close it. So we really are interested in question number 1. and what is the most important. Go down, please. So if you look at that categories, it seems like capacity building is about 1/4. Go up. And increase clinical engineering engagement locally, nationally, globally, including with Ministry of Health, over 1/3. Those are the two leading category. Increase of professional recognition is about 1/7. So it's no question that you felt that engagement is very important. And now that we see that, increased establishment of national association and global collaboration, it seemed to me like you feel that we achieved that because you don't care much for more of that. And what you, Adriana, don't say no. Do you interpret that differently? Do you read that differently? Yes. Adriana.
Yeah, Dean, what I think is that those international organizations like GCA are to support the others, to support all the members. But in reality, what we need to do is, like with GCA, empower those and bring the capacity building, training, support. But it is up to those individuals. The most important is to work in hospitals, to work in Ministry of Health. So I think there are two categories. So I would not delete the international organizations because that is something that can push or advance. I don't know if I make myself clear.
No, you're clear, and I understand that. I think that we believe that we have international organization. It's not that we're going to do away with it. It's just that we think that we don't need to build more of that, but more of the individualism, like you say. That's important, that the international organization support the individuals. That's what the point you make.
Exactly. The national societies and the individual members.
Yeah.
Absolutely.
Thank you. So now, Kali Roy, the question is, can we add what we learned to our 7 classification? Go ahead.
Do you want to see the entire poll?
The entire poll? Sure. So show us the entire. Number 3, clinical engineering involvement with decision maker, like MOH. Almost half says improve and grow closer, compared with condition of 3 years ago. So we see progress, but it seems like it's still very important to us. About the same as 3 years ago, about 1/4 of us, and difficult to determine either way, about 1/4 of us. That's not good. If we can't show you a difference, that means we didn't do enough work on that. And then number 4, do you have adequate professional development training in your locality? We want you to be able to speak on our behalf of the discipline and do your job. So you need that kind of development. And it looks to me like 1/3 saying, yes, there are plenty of training opportunity in my locality. About 1/3 saying some training is available, but not enough to meet professional needs. And then it goes down to limited opportunity. No, there is almost no professional development, and I rely mostly on online. So if you put those 3 together, you get also 1/3 saying not enough. Have you read any of the manuscript? That's why you need all the help. You're not reading the manuscript. About 1/4 not yet. I'm sure it's on your desk, ready to be read. About 1/5 saying yes, read only one. About half saying yes, I've read several. And about 5% yes, I've read most of the issue. Okay. Okay. I forgot to tell you, all those that says yes, I read most of it, are going to get a souvenir. Do you want to change your vote? Okay. Let's go and see if we can move forward towards closing that session with your involvement. That it was great. And I need to move, Mike, so I'm not taking comments. There are other people that vote. We're going to classification now. If you want to call it that way, I'm not shutting you up, but I'm moving with the program.
I'm going to ask Adriana what chances there, a very important question about making.
I realize it. We're going to move with the classification first.
Okay, you're shutting me up.
I did not.
Yes.
So we started by saying those 7 classifications are acceptable with a modification to number 4, where the words privileges we would like to add. Can we do that? It's happening. Fantastic. Then we want to make sure. Privileging. Okay. Then we want to make sure that if you agree that national policy become more clear issue for clinical engineers to get involved with, and we need to make sure by either modify measurable income through MOH, or as Adriana suggested, by taking it down in clinical or national, not, where would you say, what else? Where else you suggested?
Yeah. The measurable impact should be like at hospital, national level, and then Ministry of Health. But
okay. So let's modify number 1. And
I don't. Yeah, go ahead.
And put there, engage with MOH national policies. Engage with MOH national policy. I think we want to make it engage. So we are listening to Adriana saying, put the clinical engineer there, not just have somebody else do or not doing it. But we are talking about health technology management specifically, and we need the clinical engineers at the national level get involved. I think that is more clear if the spelling, why we have read there. Okay. Frank Painter.
Yeah, I'm wondering if number 4 and number 5 might be combined, because when we credential clinical engineers, we need to be credentialed on something. When we define the body of knowledge. Oh, thank you. Yeah, I was saying, when we define the body of knowledge, which is number 5, we're now defining what clinical engineering is, and credentialing is credentialing the clinical engineers based on the body of knowledge. So perhaps 4 and 5 might be combined, but it's just a thought. It's not a necessity.
So you're a professor in the field, and I would like to hear your opinion. Do you feel that we have a uniformity on BOK, BOP?
I think there could be. The problem is that
as was mentioned, there's different definitions of clinical engineering. There's different regional emphasis in clinical engineering. So how, you know, if we were able to come up with a body of knowledge definition that was able to encompass the entire globe, that would be ideal. It might not be as tight as, you know, to do a regional one, but then credentialing would easily follow.
Correct. I believe so.
Yeah.
Because I don't believe that we reach the point that we have definition. I would suggest to leave it on.
Very good.
Thank you. Okay. Tell me, what else? Did we lose Khalil? Okay. Tell me what else you would like to add. Ricardo.
2.3. Digital health, distributed care, artificial intelligence, skill set, but before. So we're building the skill sets. So before the skill sets, we're defining what are the skill sets that we're building. So digital health, distributed care, and AI skill sets. Just a grammatical change there. And robotics, yes. Or embodied intelligence. Yeah, absolutely.
Could I just comment on that, Yadin?
Sure.
So you could also include that with a body of knowledge and body of practice, because that would be a component of a body of knowledge, body of practice, looking ahead, looking forward.
So you suggest subset 3 of 2 to move down to 5?
Yeah, I'm saying it's an important new area for both body of knowledge and body of practice.
Okay. Number 2 says that we need the manpower.
And womanpower.
Number 5 says we are going to teach and train on that. So should we just add it into location, or you still suggest that just to move it?
Yeah, I mean, my suggestion would be to move 2, 3 to 5, and perhaps we need to think about what else could be added to capacity building in terms of stakeholder engagement, for example.
Let's give it a try. Let's give it a try, see what the audience is saying.
Comes to Adriana's point
2
about...
subset 3. Yeah, take that and make it a new 5-2. Okay. Any comment about the change? Just the change, don't... That... Okay, okay, good move. Okay, now if there were additional, just a second.
Thank you. I think there is a point that we want to know the current situation of clinical engineering across the globe, everywhere. I think GCEA right now, it has enough reach. We're aiming to increase the coverage of GCEA, but we want to know the current situation in the biomedical and clinical engineering. So first of all the member organizations, we want to know how much coverage they're covering in their region. So do we reach all the clinical engineers in that region, or the member organization is only do we hear all the voices or only some of them? We want to know, we want to create some KPIs. I think it's all under point number 1, measurable impact. But we want to know, we want to have a KPI that is a global KPIs. We want to know, are they happy?
So if
benchmarking.
So if I will propose to you to put under number 2 a new subset 3 that will say state condition analysis. What does it mean?
When we do benchmarking, we measure KPIs, we measure coverage, we measure type of service, we measure number of.
But does that imply a level playing field, which there's not?
So you need to set what you're benchmarking against. So you set your benchmarking criteria, whether your number of clinical engineers per hospitals, number of equipment per clinical engineer per hospitals.
So you call it global, but actually I think I hear you saying national benchmarking?
You start national benchmarking, and then you start regional, then national, then global. Then that way, but you need to set the same benchmarking so you can compare apple to apple. So you set your benchmarking criteria, whether it's the number of clinical engineers, type of service they provide.
Okay, so I think that what you're saying is develop benchmarking for measuring regional, national, and global benchmarking.
Yes. Because once you've measured the baseline, then you know where you are to improve or not improve.
Can we do that?
In reports, annual reports will present who achieved very good in this benchmark.
Say it again.
We can, through this benchmark, issue an annual report about the situation.
Nice.
You can add to your award categories.
Okay. Don't campaign for your suggestion.
Yadin, if I may say, new number 3 is the most important one, because we need to know how many and where are the clinical engineers, and then we can see. So it is really this proposal from the benchmarking, and we were trying to find out for the policy book in WHO. There is some information on the WHO health workforce I can share with all of you, but the most important, which actually the director of human resources in WHO, he was asking me, he said, well, Adriana, we have now the numbers of biomedical engineers, but how many are working in hospitals? How many are working in the ministry? And we have no information. So if we first know where we are, what we're doing, and what are the needs of these, then we can develop the rest and the body of knowledge and capacity building based on those needs. So I will just reshuffle the list that you have here, and then we can measure the impact. But that's just my proposal.
Thank you, Adriana. Please.
Yeah, thank you very much. I would like to make a point on the first element on the board. Engage with the national level for Ministry of Health national policies. By coming from Haiti, I presume that you all think that in every country there is a national policy well established. And this is exactly why I would like just to add that instead of to humbly propose that we could say that Ministry of Health like implementation, conduction, and evaluation of national policies. Because certain country, we have not developed for the moment national policy. That's why we can get the point at any moment. If we're in phase of implementation phase, conduction or evaluation of the national policy in terms of technology assessment. Thank you.
Yadin, we can let Hanan mention that here.
First of all, thank you, Yadin, for all your excellent work, and thank you, everyone, for coming here and sharing your thoughts with us. I was looking at all the priorities listed and was thinking over maybe we could consolidate them and into 5 major categories, which is capacity building, credential and certification and privileging, Book of Knowledge and Book of Practice, Healthcare Technology Policy and Regulation, National and International Societies, and the last is Emerging Technologies. Because I personally feel that the first one, which is measurable impact, professional recognition, are byproduct of the rest of the priorities. So these are the inputs. The 6 ones that I listed are the inputs, and the output will be KPIs, and that will give us measurable impact and professional recognition. Is that clear?
So, if I understand you right, you're
So
saying
I feel
the
that
outcome would be one classification called KPI?
No. We'll have 6 major priority listing. First one is capacity building. Second is credential, certification, and privileging. Third is book of knowledge, book of practice. Fourth, healthcare technology policy and regulation. Fifth is national, international societies. And the 6th one is emerging technologies. Number 1 and number 3 are byproducts of the other categories.
I see what you're saying.
Yeah.
Okay.
Because each listing will have its own KPI. And all these KPIs will give us impact. All these KPIs will give us recognition. So I feel that we are repeating ourselves.
So if I understand you right, you're saying, for example, number 3, professional recognition is one of the categories you're saying. Underneath, we can put number 1.
Professional recognition is a byproduct. Measurable impact is a byproduct. So, for example, if I invest in young engineers, I build capacity in young engineers.
Correct.
They will get recognized. So recognition by itself is not an input, it's an output. And the same with the impact. The impact is an output, not an input.
So what's the input?
The input is capacity building, book of knowledge, book of practice, policy and regulation, national and international societies, emerging technologies. These are the inputs. So but I feel with this list, I feel it's a bit confused, at least for me, because I feel we are mixing input, output, impact all in one list, and it's not clear.
I would like to make it clearer. So,
okay.
So I get hard time following exactly what you're saying. Stefano?
If I can just reply on this point, personal opinion, then it's up to discussion. I don't fully agree. I mean, I would agree in an ideal world where competence and capacity is automatically recognized and leads to professional recognition. If this was the case, WHO would have a department of medical devices with 100 clinical engineers and so on, and this is not the case. So that's, I think, exactly why an entity like the Global Clinical Engineering Alliance can voice for lobbying, for bringing to the correct tables the attention to the profession. Of course, if there is no capacity, then it's a void effort. But I don't think it's an automatic output from capacity. It would be in an ideal world, which is not the one we have.
Don't you think it would be part of the policy then? Because at the policy, we have different levels of policies. We have the institutional policy within the facility setting, we have national policy, and we have, let's say, the global policy. We have different levels of policy. Should it be added to the policy?
No, because this is country by country. In the US, the two are completely different. In the US, national policy will not bring a recognition.
If I may just to clarify, I completely agree with you as a systemic approach. There's inputs, there's a process, there are outputs. And we could write that as part of the gist and the logic. But here we're trying to build what we as the community of clinical engineers need to do in the next 2 years to advance the profession. So we need to look at everything, not just the inputs and expect that the outputs are just going to happen. We need to push both sides. We need to use an up-down, a top-down, and a bottom-up approach. Because if not, who is going to make the connection? Like Stefano was saying, it's not automatic.
Another example is number 7. 2 years ago, we didn't feel that there are sufficient number of national society around the world that focusing on clinical engineering and health technology management. They were subset of somebody else, but did not have their society, didn't have the recognition. So GCA selected to drive the ability of countries to organize society around clinical engineering as one of the priorities. And we do have more societies now. So this is not something that I can fit under something else. It's not. Yeah. Mladen.
Thank you. So, yeah, I strongly believe that number 1 should stay. And the reason I say that is because we as clinical engineering practitioners, health technology management practitioners, need to have tools that will show our impact on the health system broadly. And we don't have those tools. In the same way HTA is used to generate evidence for the cost effectiveness of a health technology, in the same way we need those similar tools to show the cost effectiveness, the importance of clinical engineering and health technology management. So for me, number 1 is still paramount. We need to create collectively, and that could even be part of the body of knowledge, we need to collectively do that. But the point I wanted to make was about policy. So I've got a problem with 6 as it stands. In South Africa, the Ministry of Health first developed a framework for health technology policies. And as our colleague has just said, there are many different types of policy. There's a policy on human resources. There's a policy on whatever, health technology management. There's a policy on ... So there are many policies. But there have been many policies, fantastic policies that have been written and have just stayed on pieces of paper. So we can't talk about policy in isolation. Policy needs to tie to strategy. So we need to, yes, inform policy, but we also need to drive strategy, because the strategy follows the policy, which provides the guardrails, the goals, the objectives. So I would just say that 6 should become policies and strategies, and just leave it at that. Thank you.
Okay. What I would like to do at this point is ask your feedback on the categories that we have, and if you need to vote, do you feel that there is something here that is important to you, it's not on the list?
Yadin, sorry, I seem to be
No.
too much. But there was an earlier suggestion about health technology assessment. And to me, I think that's important because it's, again, we had a discussion with our colleague yesterday, right, about how if one looks at health technology assessment and the assessment bodies in countries, they first of all focus on pharma. And then when they wish to increase their scope to medical devices, they're using the same perspectives that they've applied to pharma to medical devices. And we all know that simply doesn't work. In medical devices and technology, you talk about life cycle optimization, not the price and the effectiveness of a drug. So we need to, that's part of the stakeholder engagement, and also we need to be the initiators, the instigators, the providers of ways forward for how health technology assessment of medical devices and health technologies can be incorporated into existing health technology assessment initiatives within ministries of health. So
we
I would
have
support HTA.
We have colleagues that are focusing on HTA, And should we engage with those groups, or you saying should be separate activity for?
I would support the addition of HTA because, I mean, there are many dimensions to HTA, but I think that clinical engineers, health technology managers have got a critical role in basically taking the HTA toolkits as it's currently applied and used and fashioning them and developing them into what Ricardo said, into optimizing the life cycle management of
So
health
number
technologies.
6, excuse the interruption. Number 6 can be addition, HT policy and strategy, including HTA?
May I?
I'd be happy, as long as HTA is on that list. I'm happy.
Okay, Adriana.
Thank you, Mladen and Yadin. Okay, number 1. The health technology policies that WHO is preparing includes everything, includes the regulation, the HTA, and the health technology management. So it is a medical devices general policy. And then there's a section on the health technology management. But what is very important is how this health technology management needs to link with the HTA, needs to link with the regulation. But we have a core competency that they don't have, and they have nothing to deal with the final use of the technology. So I agree that we have to follow, we are part of the medical devices, so we can call it medical devices health technology, policies that has to be related to the national health plan. That is one. But then inside that, there is a specific area on health technology management. And exactly, Mladen, what you were saying, was a big discussion on the new HTA book for medical devices, and Pedro might remember that. There was a discussion that the hospital-based HTA, I said, no, the hospital-based HTA equals the clinical engineer in the hospital, because they are the ones that have to decide. And I agree with you, Mladen, that other people are getting our role. As the regulators are doing with, the pharmacists are doing with regulation, we're getting HTA people saying we take care of the medical devices. And I said, no, it should be us at the hospital level, but us also working with you at national level. So we have, I don't know if I'm saying too many things, but it is, we need to link with the others, but we are not responsible, fully responsible of regulation, for example. But we need to link with them and send the post-market surveys back to them. So, but we have a core competency that nobody of the other colleagues have, and we have to embrace that over.
That's what I would like to put into number 6, a strategy for engaging with HTA, rather than put it by himself, because then we seem like we're putting the red curtain in front of the bull. Are we taking it from somebody else? So, okay.
But please add engaging with HTA and with regulation, because we need to engage with these other like parts of the system. That would be my suggestion. Mladen,
and regulation.
Mladen, do you agree?
Okay, okay. I would like to see if we can, please.
Well, I know that you listed digital health and AI under the book of practice and book of knowledge, but I'm wondering if we can have a separate category for emerging technologies, and that would include digital health, AI, 3D printed medical devices, and so on.
Very smart, yes. On 5, subset 2, in front of digital health, emerging technologies such as okay. Are we good? Okay. Michael, anything else that you want to add? Yes.
Sure, thank you for the opportunity to offer solutions. And while Adriana is here, I think it's good to have her support. Adriana, about the recognition from Ministry of Health, if you remember in 2010, when we were at a meeting of Asian Harmonization Working Party, I presented a presentation. It's called From Regulation to Patient Safety, 3 Essential Steps. And that 3 steps, the third step is clinical engineering. So these are essential, and that very simple 3-stage graphic expression is what the people who are not in clinical engineering can understand. And that, I think, is a very effective message to promote about the crucial roles of clinical engineering. Would you agree with that? If you remember, and then that chapter 53 is really a elaboration of this.
Okay, if I can, Yadin, can I?
Please.
Okay, I think something that is super important is like, Tom, you remember when we did the Global Forum for Medical Devices? We have silos like, and Shenkun, you will also remember, and Pedro. We have HTA, HTM, blah, blah, blah. But the first day of the Global Forum, what we had is how to put them together. So I think it is really important that GCEA links out to IMDRF, for example, on the regulators and say, we are here with the ones working in the last mile with the equipment, with the patient. Number 2, with the HTA, Murillo and Pedro was there also. We were doing with the IFMBE and with HTA. So saying we are the ones that are using the technology in the last mile. So we are responsible for the use of the technology that was assessed. So it is really the relation with other international organizations and bodies that can make sure that they recognize us and we recognize that they are specific on that, but that we all together need to ensure that the best technology is used by patients and focused to patients. It's not a one, it is a collaboration between all of us. So linking with these international societies and being members of them, as GCA being member of these others, I think it will be a great initiative over.
Yeah, but you see, these 3 stages is precisely the expression of the World Health Assembly Resolution 60.29. When that is expanded into the management stage, the beauty of this is that we have the simple 3 essential steps from regulation to safety, to patient safety. And regulation itself is actually a product safety, right? I'm deriving this from the Green Book, from the regulatory Green Book. If you look at figure 1, there are 7 phases, and the regulation is covering the first 5 stages, then the 6 and 7 is not addressed by regulation. And now here, it took me so many years, 10 years, to develop together with the stakeholders, chapter 53 and chapter 49, which is a real explanation of what these 2 steps is. Second stage is actually assessment of the context of the user, assessment. And that is for sure. Now, also...
Sorry, you're
third,
preaching to the converted.
Okay, good. No, fine. So this is why I'm saying, do I have Adriana support that this is a simple framework to promote Ministry of Health?
Okay.
And if not, please tell me why.
Okay. Thank you, Mike.
Not right now.
I don't think that her role is to explain individual question. It's more about classification. Let's go ahead and see if we can bring this to conclusion. What I would like to do is take what I would call informal vote, because the voting machine is not working. And as you see, we're going to say after the informal vote, we'll send it out to you and see if there is a regional preference to work on specific categories. So let's say number 1 become number 5 and number 2 become number 1. You will have a chance to vote if that's the order you accept, and would you prefer to take a specific topic and focus your region work on addressing this challenge. Is that clear? Okay.
Try again.
You see the corner? Go see if I'm there. Okay. Let's try and bring this to a closure, and we will basically use a show of hands at this point. So, and you can use only one hand. If you see the list as it is, would you agree that this is the priority that you would like to maintain? Let's see, show of hands. Please.
I didn't know you could still run. I really liked our friend mentioning about 3D printing and all that, emerging technologies, robotics. I don't think digital health and AI should be bundled with emerging technologies, because a whole lot of material science technologies are also emerging, and it might be confusing to have digital health and AI with robotics and 3D printed implants, for example. And as you know, 3D printed implants would have actually nothing to do with digital health. So it might be better to segregate them. Digital health is a very complex topic. Somebody like Elliot has to really make path into it, and may not be a good idea to club. The 5 Roman number 2, I suggest we break it into emerging technologies and keep digital health and AI separate. And if you agree to that, then I would be happy to take on 5.2 emerging technologies for our region. Thank you.
Good job.
You know, we in the Italian mafia like offers. So let's take 5.3, make Ricardo happy, and we'll move AI, embodied intelligence skill set, to number 4, to subset 4.
It goes a bit further into. Yeah, embodied intelligence, yes. Yeah, digital and AI can stay together, and embodied intelligence is an emerging technology as well. It is robotics, but I don't like to just restrict it to robotics, because people get the wrong impression. And we're looking at embodied intelligence, like this chair could be something that's sensing and then can move as I rise to help me get up, examples like that. Yeah. Okay.
Okay. You can take your offer from the table, regardless of the changes. Okay.
Yadin, can I comment quickly?
Please.
Okay, number 1, CE, Health Technology Management, measurable impact. So one is, do we have impact in national level policies? But then the second one should be at the hospital level or the health facility level. There is no about the health facility level. So if we save lives, if we better management, better use, better everything, there's nothing on number one.
So
Then it said,
the way that we wrote it is subset 2 in number 1, where it was health system. You can see industry, academia, regulatory stakeholder. Health system was intended to be hospitals.
Okay.
Otherwise, we don't have role there.
Okay. Okay, thank you.
Patient groups.
Stakeholders, patients, patient groups.
Stakeholder, patient group. Yeah.
Emerging technologies and embodied intelligence, that is part of capacity growth, not part of the body of practice development, at least not yet. Whereas digital health and distributed care are part of the current body of practice development. Emerging technologies are, I think that's becoming practice, like robotics.
So under number 5, Ricardo, under number 5, it's the practice. And under number 2, it's the competency.
Correct.
It needs to be both.
Yes, or
Both,
either in both or
yeah. Okay, put in both. Put in both, and that is the 5 subset 2 copy under number 2 subset 3.
And Chaitendra said he was going to do that in his region?
Omar.
Make it more general and for example, today we are talking that the whole healthcare system is talking about value-based healthcare. What biomedical engineering is doing or contributing in value-based healthcare, this includes patient group and also the healthcare worker, the whole healthcare system policy followed right now by WHO. So if we can find our place in the value-based healthcare concept, we can find our place in the WHO. So instead of patient group, I suggest to make it value-based healthcare.
That's not a replacement in my mind.
I think we need both.
Go ahead, Adriana.
I think we need both because the patients groups are national, local, etc., and the value-based is another one. So it would not replace one another over.
So we might be ready to vote?
Okay. Patient group, comma, and value base. Okay. I think that we expanding the subset too much, but that's okay, as long as we have the categories. So we have 7 categories. Nada? This is the voting, so you can vote it to move it up.
Yeah. We are still at 1. I'm trying to move to number 2.
Well, you have to campaign your vote. Okay, let's do that.
Yadin, would National BME Society Development not be part of professional recognition and benchmarking? Would they be separate?
No, that's
number
good.
7.
That's good, but several years ago there were not enough national societies,
Okay,
and we
so
wanted
it's a priority by itself.
And we wanted specifically to go out and teach them how to create national society.
And then get professional.
Exactly, exactly. Okay, let's vote. Let's see if you want to change the order, and then we'll take the region and see if you have preference to deal with one or the other.
She's going to put the voting numbers in the chat. For those online. Or for those online.
Okay. Okay.
Input from the chat, from the people online.
Okay. I feel like a robot.
Can you take the trash out?
We're going to put for the people out there voting with their phone the numbers of the categories as you see it here, and ask them to vote their priorities on those numbers on the chat. Write the numbers on the chat. I thought I said that. We're going to put the categories, write the number on the chat that you want it to be highest priority 1, second priority 2. And now let's do it in the room. Okay? Think about the list. What do you think should be number 1? Number 1.
Number 5 should be number 1.
Who is on 1? Who is on base 2? I'm kidding you. I got your point. Okay. I'll take Ricardo's proposal. If I take number 5, how many of you want to see it as number 1? Please raise a hand. We take category 5 and vote to see it. Do you want to have it most important by ranking it number 1? 1, 2, 3, 4, 5, 6, 7, 8, 9. Did you vote? Okay. 10. Okay. 10. Can we put next to 5, 10? Now let's go by the order. Number 1. How many of you feel that number 1 should be number 1? Please raise a hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Are you just waving for me or are you voting?
Voting for number 1 is number 1.
Okay, we don't know yet. This is 14 votes.
She's voting for that.
Okay.
I think you counted her, so 14.
You writing it or you not on the screen? Okay, number 2. How many would like to see it as number 1? Please raise a hand. 1. Okay, 1. Oh, nice. Thank you. I didn't see that. Okay, 2. Number 3. How many of you would like to see that as number 1? Please vote now. 1, 2. Okay, 3. We have 3. Number 4. How many would like to see that as number 1? Raise your hand. Is Noe voting on this one? Okay, number 4. 1, 2, 3. Let's go to number 5.
You got 10. You can
Number 6. How many would like to see that in highest priority? 1. Nothing on the screen. Say 1. Okay. And number 7. 1. Okay. No vote for number 7. Great. So according to the votes that you have, number 1 stays number 1.
But number 5 becomes.
We wasted an hour.
No, it isn't. 5 becomes 2 though.
Okay. Okay, based on the vote online and in the room, you're reorganizing it? Okay. That's what we meant by after voting, this priority will be assigned by region. Okay. Do you see a particular classification category that you think that people in your region would like to work on? Okay. 1 and 2. Now I got it. Okay. Can you put on the line, on 2, 1 and 2, 2, AMTZ?
And we might not get something for region for all of them, so we might
Yeah.
get what we get.
Anything else that you see here that you would like to pick up and say, we are interested in our region to work on that? Omar? Okay. And I think, Jitendra, you said 2 of them, right? Or just numbers? That's what I thought. Okay. Can you put 2 subset 1 also? Yes. Okay. I don't want to just drag it on and on and on. Do you see something that you would like to be associated with? If not, that's fine. We're going to be organizing that in a form and send it out to you. Elliot.
It put us down for digital health and distributed care and AI.
And who's the us in this case?
That
2 numbers.
Foundation for Living Wellness and Health, FLWH.
FLWH.
2 subset 3. Great.
In our free time.
I thought that you were.
Thank you, boss.
After hymns. Okay. Tom, come and.
Adriana, question.
Adriana, please.
Yes, Yadin, I'm willing to help in number 1 and number 6, but I also would like to see if there is, now that I'm former WHO, if there is an initiative or a proposal that GCEA supports anybody from working in a ministry that is willing to have a proposal for a health technology management World Health Assembly resolution, because that it would be ideal that that happens soon. I could support or help whoever is going to, if there is any government, but this has to come from a government, not by an international organization. But if there is anybody willing to, I think it will make a huge change in ministries of health. And so if there is a resolution on health technology management, thank you.
Thank you. I think that this will be easy to find some higher level people that are not in the room today. They couldn't make it, but they are interested in this.
And Yadin, I'm low level, but I'll help her organize it.
Tom is.
Thank you, Tom. We need to find out people that are working in the government at higher level to see if they're interested, and then we can support. Over.
Agreed.
Please. Okay, put number 1, MIPA, but again, Adriana would say she needs somebody from the ministry. Okay. The feedback from Saudi that we will get the Ministry of Health involved.
I can share with Adriana what we have done in Jordan. I'm a member of the HTA committee, the government.
So we need those connections. Hashem, do you want your name there? Okay, Hashem and ministry. Okay, good.
It's under approval. Once it's approved by the minister, then I can share.
Okay.
Jitender, could you also deal with 3.3, which is the education capacity building?
Absolutely, it goes with 2.2.
That's what I thought.
Yeah,
okay.
2.2, 3.3, and that's why I didn't wanted them separate, because they would go with each other.
Right.
But if they are kept separate, happy to deal with 3.3.
Perfect, thank you.
Thank you. Okay. Let's bring it to a close. Tom, if you can join me, I would like to thank you very much for opening it up and remind us what happened 2 years ago and how far did we go. And I think we got a very good interaction here, and we did a lot of good things. Adriana, thank you from the bottom of our hearts.
For 16 years plus the other 30.
17. Almost 17. Almost 17.
But that goes to show you how much we can work together and do things. Thanks. Elliot is kind enough to memorialize the moment, and he brought some souvenirs that he would like to share with you guys. Okay, take one as you're coming out. And what I would like to remind you is that finally we are going to take a photo.
Surrounding Adriana.
Yeah. With the hats, yes, yes, with the hats. Is the photographer here, Amy? Can we take a picture with Adriana on the screen?
Please.
If you would like to come and sit here, please, we'll take a picture with Adriana in the background. Yeah, that's what I'm saying. If you can stand here, please. Raminda, come on. Hashem, move. Come on.
Thank you.
No, stay. Otherwise we don't see it well.
My heart, my mind is with all of you.
Okay. Michael, come on. Done. Frank. Oh, She's ruining the Congress. We need you here. Yeah, because we don't see the screen. Stand here. Down, down. Down, down, down. We don't see the photo otherwise.
Yeah, then I have my white pen to remember that the patient goes first, and then the technology to support them.
Yeah, okay, okay. Any heads left? Okay.
Are all the panel, all the participants can turn their camera or not?
Thank you. Okay. What? Oh. We need Ricardo. Ricardo, move towards the center. Manish, Stefano, take more. Calm down. Calm down. Okay.
Adriana, bye. Jitendra this side.
Bye-bye, Adriana.
Bye-bye, Adriana. Thank you.
Hi, Jitendra. Thank you very much.
Okay, Dr. Lee. Dr. Lee, so Mr. Jin said there's another photos booth that we can pick picture there. So yeah.
3 pictures.
Yeah. So everybody, let's go out and then take another round of photos with flags and everything.